Thanks for joining the People of Precision Health podcast, a series by Vibrant Health where we discuss the unique challenges of building human cohorts for health and clinical research. We talk with experts in population genomics and precision health to explore novel methods and real solutions for engaging the humans behind the data. Joining me today is Dr. Jay Patel, chair of the Department of Cancer Pharmacology and Pharmacogenomics at the Atrium Health Levine Cancer Institute, where his research focuses on translational and clinical pharmacogenomics and pharmacokinetics of anti-cancer therapies, as well as managing and mitigating cancer-related symptoms. Dr. Patel also serves as an associate professor at the Wake Forest University School of Medicine and as a part-time palliative medicine clinical pharmacist. So welcome, Dr. Patel. I'll call you Jay. Thank you for allowing me that. I am really excited to talk to you today, and I really want to start with something we talked about when we first met. You and I spoke previously, and you kind of shared a very remarkable, in my opinion, history about how pharmacogenomics research began at Levine Cancer Center or Cancer Institute and the vision for patients. And I'd like to start our conversation with just an overview of that history again.
Yeah, absolutely. Well, first off, it's a pleasure to participate here, Molly. I appreciate the invitation. And yeah, I've now been at Levine Cancer Institute for almost 10 years. In August, it'll be 10 years. And, when I first started back in 2013, I had actually just finished up my postdoc fellowship with actually Howard McLeod, who was also on this podcast a few episodes ago. And my fellowship really focused in cancer pharmacogenomics. And I was really brought on board to Levine Cancer Institute, or LCI, to really help build their cancer pharmacogenomics program essentially from scratch, because LCI at the time was really only a year or two old in terms of being a very new established cancer center. And so I really felt at that time a successful program would really be sort of multi-pronged and really span across the entire translational research spectrum from gene discovery to gene validation, and really establishing the clinical utility with prospective interventional trials, all the way through implementation into practice and policy. And so that's really exactly what we set up. And so early on, being a new cancer center, we really had to establish the infrastructure to be able to do this sort of translational science, right? So we needed specimens to be able to do any research with. So we had to begin with specimen collection protocols, a biorepository, really begin banking DNA for future gene discovery and validation work. And a lot of the work that we focused on were looking at genetic predictors of drug toxicities, things like chemotherapy-induced peripheral neuropathy, cancer pain, venous thromboembolism. And so we had originally focused on that as being a large portion of our sort of gene discovery and validation work. And then we also began running clinical trials, prospective trials that were really then focused on genotype-guided dosing. This could have been for cancer therapies as well as supportive care therapies like opioids or antidepressants. And so while we were really building that overall research portfolio, we were also simultaneously building protocols and SOPs that were focused on how do we best integrate evidence-based pharmacogenetic testing into clinical practice for drugs that actually have well-established guidelines. So again, for drugs like fluoropyrimidines or thiopurines, or even supportive therapies like voriconazole, again, how do we establish SOPs that benefit our patient population? And how do we best incorporate that into clinical practice? And even as we do that, we have to think about the implementation science piece of it, right? So as we're integrating this potentially disruptive technology, how do we establish certain implementation metrics to ensure that we're doing that the best way possible, that we've got equal access to patients across the board, and again, that we're not sort of disrupting the overall workflow. And then the sort of last piece of that was, again, kind of going through the entire translational research spectrum all the way through integration. Once we do the integration piece, how do we establish the utility of digital health? And how do we best integrate genomic data into the electronic medical record? in a way that is user friendly for providers, that they can access at the point of care in real time, as well as providing those results back to patients. And so I'm sure we'll get around to some of those other details later in the podcast, but that was really a big focus when we had first started. And we've made a lot of progress now, I think, over the last 10 years to make that happen.
Yeah, I love it. And something you just said about just making it accessible reminded me also of something that you had mentioned in our previous conversation about making research, basically implementing something that could become research without walls. So many people suffering with cancer or being diagnosed with cancer are just geographically undesirable for research. Treatment they may be able to get, but the research, is notorious. Cancer research is notorious for being a little bit harder to decentralize because of, as you've described, the biobanking and the number of specimens and the number of tests and other reasons. But being harder to decentralize, virtualize to an extent where it's really going to give us the benefits that we seek. So I want to explore that a little bit, because as we talk about the need for diversifying patient data sets for creating therapies and treatments that benefit everyone, um, it's important for us to explore this idea of research without walls. So, what are some of the unique challenges you really see in being able to become a more digital first research enterprise?
Yeah, definitely. And our founding president, Derek Ragavan, really kind of coined that term for us, Cancer Center Without Walls. And when he first built LCI and really focused on expanding that from its main hub in Charlotte to now over 25 sites spread across the Carolinas, he really made it a priority to ensure that research and clinical trials were available at most of those sites, and that best practices were sort of standardized across all sites. And again, he sort of termed this Cancer Center Without Walls, where really the emphasis was that geographic location should not dictate the type of care you receive, or your accessibility to innovative cancer research. And that includes things like genomic testing and pharmacogenetic
Mm-hmm.
testing. So again, if we're offering that at our main hub in Charlotte, we need to make sure that that's accessible at every single site. And so, the care that a patient with metastatic lung cancer would receive by a thoracic oncology specialist at our main facility in Charlotte should really be the same exact care that that patient would receive if they saw a regional site,
Mm-hmm.
where maybe there's only one or two oncologists that are treating everything from plasma cell disorders to breast cancer to prostate cancer. And then that was also really made possible by our founding chair of solid tumor oncology, Ed Kim, who's now over at City of Hope, who really helped spearhead this sort of interactive, electronically accessible treatment pathway system or software program that also integrated research and trials into it. And I think that that was a really key piece of how can we ensure that every single patient being treated in our system, which is over 20,000 newly diagnosed cancer patients each year, again, across both rural settings, urban and suburban settings, how do we make sure that everybody is treated with clinical excellence, best practices, and has the same resources and accessibility to clinical trials and research? And so developing these pathways and the digital infrastructure to be able to ensure that our providers have knowledge and access to what trials are available,
Mm-hmm. Yeah.
where are they available, what's required for those trials, in what particular setting, in what disease, what line of therapy, what biomarkers might be required for that particular trial. They have all this information at their fingertips on their iPhone, iPad, on the computer, via links in the electronic medical record, et cetera. So that was really critical to allow for us to be able to really decentralize the operation. Although we have a central hub, our research headquarters in Charlotte, and we have one clinical trials office, we have one investigational drug services pharmacy that services all sites, we have one data safety monitoring committee. However, again, we're able to equip all of our regional sites to be able to be these multiple spokes across the Carolinas to allow for patients to enroll directly from any one of these sites. And so that, again, I think was really, really critical for us to ensure that we were able to reach all populations, especially our rural populations, and allow for really an efficient mechanism for patients to enroll in the clinical trials.
Mm-hmm.
And not only for clinical trials, but again, access to genomic testing, those pathways, which are again interactive tools, a provider can actually order genomic testing directly from the pathway system as well. So then that inquiry goes directly to our biorepository team, who then works on the tissue collection piece, sending off that tissue to whatever lab it needs to go to for testing. We have a clinical cancer genomics program led by Carol Farhang-Farr, who then really receives those results, funnels them in through molecular tumor boards, and then gets those results back to the providers with sort of a one-page summary of here's what you got to do, right? Here's not the 80-page report from Caris Tempest Foundation, wherever it might come from, which is critical information, but usually information that the provider just simply doesn't have time to really digest. And so we translate that information for them, and we built our own translational program to be able to do that and match it to clinical trials, and then give that directly back to providers. And so I think that again has made it a very a unique infrastructure to make it possible for us to again kind of decentralize all operations from clinical excellence and best practices to clinical trial enrollment to access to genomic testing.
Yeah, and as you describe it, it sounds so well thought out and so efficient. But there had to be some really big obstacles that you overcame in developing the infrastructure. You know, in this podcast, we typically are talking about patients and how do we better support them, engage them, enroll them. So I'm going to ask this question. There's probably a ton of answers you might give, but I'm interested to know, and let's keep the scope within specifically the patient experience and participants in research. But what would you say were the biggest obstacles that you had to overcome with really digitizing some of these operations? And yeah, take me through that a little bit.
You know, I think one of the things was actually establishing an infrastructure that was nimble enough to be able to make sort of these real-time updates, whether it's for clinical trials, research, or clinical practice, best practices, right? So really, in order to set up some sort of clinical decision support program for providers, that program really has to be adaptable to change in the scientific literature. It has to anticipate the needs of providers, and it has to be actionable information. And that really took time for us to think it through and figure out, how do we develop this? Who do we have to partner up with to get this to happen? What sort of administrator support do we need to have to be able to say, okay, well, if there's a new FDA approved option that comes out today, how quickly can we make an update to our pathways to ensure our providers know immediately that that drug is available? Or as soon as a clinical trial is open to enrollment, how do we make sure that the provider knows exactly when that happens? Or if something's just suspended or close to enrollment, how are we relaying that information back to providers in a very in sort of real time? And that, I think, was a big challenge very early on, that again, really we had to focus on the technology piece of it, because it wasn't that we could email folks and say, hey, FYI, there's a new trial open. We just know that, it's a matter of fact, most of us are just too busy to be able to read every single email that comes across our inbox, especially for providers who are seeing 30, 40 plus patients a day. Mm-hmm. And so we needed to figure out a mechanism to bypass that. It wasn't going to be communication. It wasn't going to be email blasts that go out to say, hey, we have a new trial open, or hey, we're initiating this new pharmacogenetic test. So we use that pathway system as more of a central approach to say, here's where all the information is going to be housed. With one click of a button on your iPhone, while you're in the room with the patient, you can pull up all that information. So you can pull it up and see, for first line metastatic, non-squamous, non-small cell lung cancer that's biomarker positive for some particular mutation, what's the best practice? Or where do we have a first line option for a clinical trial, or second line? Is it a phase 1 trial, phase 3, so on and so forth? And what's the eligibility criteria? Right, so that was a key piece of information. And we can't require our clinicians on the frontline setting to memorize every single eligibility criteria.
No, absolutely not.
It's just not possible. So again, how do we equip them with the digital tools that allow for the system to take care of that? And then as they quickly review that one page, so in less than a minute, they should be able to review it, at least some of the initial criteria. And if that patient may be interested, may be eligible, then again, one more click, that patient goes directly to the CRA to actually then review the full criteria. And then they have 48 hours to get back to the provider to say, yes, your patient is eligible or not. And these are the next steps in terms of on-site consent, e-consent, virtual consent, so on and so forth. So
Right.
I do think that that was probably one of the largest barriers up front. That took us, again, quite a bit of time to pass that, but we were able to pass it. I think we've been pretty successful in doing so now.
Yeah, I find it incredible because I'm thinking about my own family history and going through the diagnosis and the fear and that moment of care, that point of care, equipping a physician or clinician to be the one with the next step immediately is so valuable to the patient experience. And I think providing that point of care, it's like a triage. Like you said, what is the best practice based on what we've seen. And so I think that this is the way of bringing research to the point of care in equipping those frontline clinicians in a better, more effective way. And then the next step, of course, is to equip that patient with the tools to take the next step. And so that e-consent, and those are the things that we often see in our collaborations, is equipping them to then feel that they're understanding what they're consenting to, doing the consent, performing the online screening, and then be joining the research program or the clinical trial. And I see you've taken so many steps that direction to simplify it for patients who may be very fearful at that time. They don't know what the diagnosis means to them, and giving them actionable next steps is so powerful in giving them a hope for the future. Now, genetics is, of course, a powerful part of research today, but the holy grail, as they say, to use that term, is the combination of genetics with additional phenotypic data, clinical data, SDO, so many other elements to create a picture of the whole human, and doing so at scale. Um, but genetics likely and obviously play a part over time in the experience of the patient at Levine. So, how do you see genetics and the role it plays today evolving in the future? Do you see ways that it could change? I mean, you're already on the cutting edge, I think, but what do you think is the vision?
Yeah, I think right now we're sort of in a situation still where I think there's a lot of reflexive tests being performed, and that's kind of routine and part of the patient experience along the entire kind of cancer care continuum. So for example, a certain diagnosis, let's say particularly at a younger age, may warrant germline disease risk testing, potential cascade testing of family members. Um, a certain diagnosis of, let's say, lung cancer, again, may warrant a reflexive test for a number of biomarkers, PD-L1, EGFR, KRAS, ROS1, et cetera. And then from a pharmacogenomic perspective, again, in order for, let's say, thiopurines would reflexively trigger a TPMT or NET-T15 test. In order for a fluoropyrimidine would trigger a DPYD test, so on and so forth. Most of our patients at this point that are undergoing kind of more large-scale next-gen sequencing panels typically do it usually after recurrence. And most even of the large multi-gene pharmacogenetic testing panels, we're still doing under research protocols. So I think over time, I really expect not only for the volumes of all these to increase dramatically, but with things like NGS for cancer genomics to probably occur earlier, incorporation of things like serial liquid biopsies to occur earlier, at baseline, throughout treatment, to really monitor risk of progression, as well as transitioning some of those larger multi-gene pharmacogenomic panels from research to routine clinical practice. And again, this is all going to generate lots and lots of data, right? So how do we figure out how to best apply that data
Hmm.
in real time to aid our providers. And so I really see that there's going to be a massive influx of genomic data combined with all the clinical data in our electronic health record. And that's really going to be quite problematic if we don't figure out a very good mechanism to handle that data.
Right.
And to work with our third party vendors in figuring out how can we actually optimize the integration of genomic information, clinical information, scans,
Hmm.
other pieces of clinical information, patient demographics, to actually then come up with the best possible treatment option for a patient. And a lot of this is going to be AI driven, right? I think that there's going to be multiple tools out there. There's so many folks working on how can we in real time use all the information that's been digested into the electronic health record and continuously mine that information to say, okay, well, if patient X comes in, we can run a program and see, well, they were like patients A, B, C, D, and E, and F that responded very well to this other treatment, whether that's again based on biomarkers, other clinical information, age, all sorts of stuff. And then say, okay, well, based off of this information on how we've treated other patients, this is what we feel like is going to be the best option for you. And again, their data is going to funnel back into that loop to then reinform the overall program. And that's going to keep happening with thousands and thousands, if not millions of patients eventually. And a lot of that, I think, is going to continuously keep informing this mechanism of precision medicine and personalized medicine.
Yeah, I love it. And some of what you said earlier in your answer was especially exciting to me because the things that the studies I really have my eye on are these investigational approaches to let's pre uh, what are the precursors, let's say. Let's start to do research with populations that do not have a particular cancer, but could potentially be more at risk, either because they are related to someone who has these has the cancer or they have some genetic predisposition. I find that interesting, but as you say, that opens up a much larger data set, a lot more potential questions to be answered, and a lot more potential kind of ancillary findings that
Mm-hmm.
we're going to need a bigger boat, as they say. And you mentioned the need for artificial intelligence and mass data processing, mass data analysis to occur. I think it's an exciting place to be, though, right now from a research standpoint. However, it's also very scary, I think, for some patients. And as we gather more data, as we're asking for more and seeking more data, we do still have the burden of trust to kind of bridge that gap with patients. And as we're asking for access to more of their data, or potentially asking them to engage family members or people who maybe are within their realm of influence, we have to help them understand something that is very, very complicated and very complex. Most people do not have any understanding of what genetic data reveals about them. They may have fears about, will this impact my insurance? Will it
Mm-hmm.
impact my ability to be employed? And that particularly is a fear in the underserved populations who have less exposure to it. So I'm interested to know about how LCI is handling the education process, because we really have to bridge that gap with the patients if we want to do the right thing by them, and also if we want to be able to access um, their data.
Yeah, absolutely. And from a perspective of, let's say, pharmacogenomics, there's going to be multiple stakeholders involved with every aspect of the genetics experience for patients. So with pharmacogenomics, we do a lot of targeted outreach to our clinical pharmacists and nurses who, again, are on the front line doing a lot of the chemo teaching. Um, we're focused on providing patient-friendly handouts that explain pharmacogenomics. We've built within Epic, our electronic medical record system here, a mechanism for patients to access their pharmacogenomic results. But that's not where it should stop, right? Because that is still very difficult information to understand. So we're also providing supplementary information, patient-friendly handouts, patient-facing material that explains what is pharmacogenomics in multiple languages. What is pharmacogenomics? What do these genes mean? What do they do? What drugs are they related to? And so they will always have access to that information. And then in addition, if they need further guidance and assistance, they always have access to our pharmacogenomic consult team as well to provide additional resources to meet with the patient one-on-one, in person or virtually, to further go through those results. And then any patient who also undergoes multi-gene pharmacogenomic testing will also have a consult note that's written specifically for that patient, and that'll be uploaded to their chart. And that's something that both the provider and patient have access to as well. So that's one piece specifically for pharmacogenomics. If I think about cancer genomics, it's a bit more challenging because, again, that we're talking about a lot of our medical oncologists really being equipped with the ability to understand, utilize, and apply genomic information in real time. And again, we use a lot of digital tools to make sure they've got those resources at the point of care, access to molecular tumor boards and all these things. But in terms of how that then gets related back to the patient, becomes a bit challenging because this is very, very complex information. And so we do work with our medical oncologists, pathologists, a number of different stakeholders who participate actively in our molecular tumor boards while we're going through what is the relevance of all this sort of information. What are the incidental findings that were identified? What sorts of referrals then need to be made to our genetic counselors to confirm any germline results? And then the genetic counselors meeting one-on-one with the patients to explain what those results mean for them as well as potentially their family members. And so, like you mentioned, this is really critical for our underserved population as well. And there was a recent publication, I believe it was late last year, from one of our LCI teams. This was published in Journal of Clinical Oncology, the Clinical Cancer Informatics Journal, about our clinical cancer genomics program, which again incorporates this molecular tumor boards, clinical decision support tools, trial matching, patient engagement. And what we saw was when we instituted this program, it not only resulted in really a massive increase in the use of molecular profiling itself, because now providers felt comfortable ordering the test because they had a support system. It also led to enhanced clinical trial accrual, which meant, again, more patient engagement. But importantly, the proportion of African American and Hispanic patients that underwent testing was actually the same as that in the overall health system. So that was really ensuring that it wasn't that we see 20% of African Americans, but only 2% were undergoing molecular profiling. It was that 20% of our patients that underwent molecular profiling were of African American descent. So again, really ensuring that they had equal access to care, reducing these health disparities was really critical. And that was something that was, I think, really exciting for us to see.
I use my father's example so often because he's in his 70s, but he's Latino. And I look at him as somebody, we need his DNA represented in a lot of these research programs for so many reasons. But a lot of times, research leaders and research programs are so focused on getting things done with a very skeleton crew often, and they're trying to make it easy on the team and easy for them to get the research program launched. They forget about the importance of streamlining the process for the patient to get into the program. And I think your results show that when you put the focus on the patient, the patient's experience, the patient's feelings of trust and support, the making it easy for them to say yes to the research, you see a much better response and better enrollment numbers into a trial or recruitment into consents into a research study, which is really, I think, something that we are working to flip that switch in most research studies to help scientists realize it's about the patient and making them feel comfortable with your research. So question about that, though. You are doing so much. Where do you think there is still opportunity for you to improve patient support? Where are there some new opportunities in at LCI that you'd like to focus on using digital methods to improve either patient engagement or patient experience? Where are still the new goals for you?
Yeah, I think an area that we've been, again, quite successful in, but we're really trying to figure out how we can continue to ramp it up and ensure that we've got more screening to have the necessary triage services is one aspect of this is electronic distress screening, which is something that, again, is recommended by NCCN guidelines and ASCO guidelines, but not every center does this. And I think it's difficult to do to screen every single patient walking through the door for multiple symptoms to ensure they have equal access to subspecialty care. But it is something that we've done, and we test about 20,000 or probably over 20,000 patients per year on an electronic distress screener that asks questions from what's your pain level, anxiety levels, depression levels. Are you interested in clinical trials? Are you interested in genomic testing? What financial concerns do you have? There's over 30 different questions that they answer. Depending on the answers to those questions, and all this again is done electronically and then inputted into the electronic medical record. And certain answers can then trigger referrals to, let's say, palliative medicine, cancer rehab,
Mhm.
financial services, genomic testing, again, clinical trials, all sorts of things. And that I think has been a really neat mechanism to ensure that along that entire cancer care journey, patients are getting access to the resources that they need based off of the symptoms that they're experiencing. And another mechanism to ensure that that occurs is their access to nurse navigators as well. I think this is such a critical component that I wish every cancer program had nurse navigators. We have heavily invested in our nurse navigator team. We've got, I think, over 30 nurse navigators, and they literally help navigate patients through the entire cancer care journey. That includes triaging for care, appointments, emotional support, again, access to research, helping the patient understand how do I get involved in a clinical trial. Um, they have access to those pathway systems and all the digital tools to know what clinical trials are open, which ones aren't open. So again, they don't have to be experts on every single study or every single disease state or what's going on. They just need to know who to talk to and how do I get the patient to have access to all these different programs. And again, kind of going back to some of our underserved populations, one of our studies that have been published looking at large B cell lymphomas identified that there was actually similar survival between white patients and minorities. Part of that was due to equal access to guideline concordant therapies, but also the fact that minorities actually received higher intensity navigation encounters. They were more likely to require and utilize nurse navigators, which actually helped them, I think, to overcome a lot of the socioeconomic disadvantages. And so I think that that, again, is something that we try to push for across all of our clinics to make sure that any patient who needs nurse navigators, who requires that extra level of care, has access to it. So that I think is one piece. The other piece I think is as we're thinking about what sorts of trials we're doing and how we're screening patients, how we're incorporating digital tools to do that, is to actually do trials that are more pragmatic and inclusive of real world patients that we actually see in practice.
Mhm.
And then I know that there's been a big push by ASCO and Friends of Cancer Research and many other organizations to look at how do we broaden sort of eligibility criteria to focus on those real world patients. And one of those examples with the Pragmatica lung cancer treatment trial by the NCI. I think one of the first trials sponsored by NCI that's really focused on this more pragmatic nature design. This is being led by SWOG and Alliance as the cooperative groups, but really looking at, again, removing some of those barriers that really prevent people from joining clinical trials, like things like poor performance status or age. But even how do we make it less burdensome to the sites that are conducting the studies, right? How do we do less frequent visits? How do we allow for e-consents? How do we allow
Mhm.
for virtual visits to monitor for patient-reported outcomes? Let's remove unnecessary blood draws. All those sorts of things, I think, are going to make it so much more efficient for patients to want to enroll in a trial and for sites to actually want to conduct those trials. So yeah, I do think a lot of these things I think are going to kind of help that overall process to make it much more efficient, more patient centric, which I think will hopefully increase enrollment on some of these trials as well. Again, I think across the board nationally, we're still at much less than 10% of patients enrolling on trials. Our benchmark here is to get at least 20% of patients, which we've been able to achieve. And I think a lot of these mechanisms that you put in place will help you achieve that.
Yeah, I just see so much promise for it in the next few years. So there are a couple questions I like to ask everyone about their field as we kind of close our conversation. So the first one is, where do you see, if we think about oncology research and the use of pharmacogenomics in oncology research, where do you see the next immediate big, what is the next big thing, do you think, the next big disruption in the next 3 years or so? And then we'll look a little further in the future. But let's start with the short term.
Okay. So I think specifically looking at pharmacogenomics, I think more immediately in the next few years, I think a lot of us are doing, again, single gene reflexive testing, right? Again, if you're being ordered a specific drug, trigger a particular pharmacogenetic test. And again, that's not even being done universally across all centers. So again, that transition from single gene testing to, I think, larger multi-gene panels. And a lot of us are already doing that, but it's usually being done under a research protocol or research setting. And that, again, tends to then limit the populations that could potentially benefit or have access to those sorts of tests. So I think transitioning from single gene to multi-gene, from research protocols to routine clinical testing, and ensuring that that information is embedded within the electronic medical record. I think there really needs to be a more concerted effort, and I think we'll see this over these next few years, where all electronic medical record systems have the ability to house discrete genomic data, and for that genomic data to trigger alerts along the lifespan of that patient anytime there happens to be a drug-gene interaction. Because at least for germline pharmacogenetic testing, that information is going to be relevant for the life of that patient. And for a system like ours, that's a pretty large integrated health system, even though a patient gets tested, let's say at LCI, they're likely receiving their cardiology care within Atrium Health, the primary care, rheumatology, whatever it might be. And even though we do testing for a specific drug here, that information may be relevant for dozens of different medications that that patient may receive from a dozen different providers. So how do we ensure that that information follows the patient? And so standardizing the way that clinical decision support is going to be used and ensuring that every provider has access to it and that the patient has access to it and the return of results. I think that that entire process is something at least we personally have been working on for the last several years to ensure that in the next 2 to 3 years, it's standardized across the board. That a patient presenting here, we know exactly what test they're going to receive. We know how long that's going to take to get the results, how they're going to get the results, and where those results are going to go in the electronic medical record. And I think that's really the only way that something like this is actually going to be successful.
Yeah, it's powerful to think it's almost it's so close, and it's within potentially a couple of years that it will be reality, or at least very close to reality. But what do you think? Let's put your visionary hat on. Next 10 years, what do you think? Where do you think it's going? Where is genomics going to play the biggest part in oncology research in the next 10 years?
I would love to see something like the All of Us program be universal, right? Where it's, again, not necessarily a research protocol or research setting that you have to enroll onto. And then even then, if you identify actionable results, a lot of times those have to be reconfirmed via certain clinical tests. But the fact is that it's a population health screening program that everybody has access to locally, regionally, nationally. So when you present to your hospital system, wherever you're receiving your care, that you have a large panel done. That, again, if we look at oncology specifically, we can cover many different areas because, again, you've got cancer genomic testing. And if you're going to go next-gen sequencing, that you also have a paired analysis of your germline DNA for disease risk, but also pharmacogenomics. And we're not quite there yet. But I anticipate, I would surely hope by 10 years from now, that every patient presenting to our cancer center undergoes those two tests, whether it's whole genome or whole exome or some supplemental sort of platform. But you basically have whole genome sequencing performed on your tumor and the germline DNA. That information then informs your care of what targeted therapy or immunotherapy, what cancer treatment are you going to receive. The germline information is informative for potentially, again, what dosing may be required for that particular therapy. And then the other germline information is what other risks do you have for other diseases? And then how do we triage that care to other subspecialties across the entire health enterprise? I think a big question of that as well is what's going to be the issue regarding cost and coverage and reimbursement, right? And again, we're seeing a major shift where a lot of these NGS tests are being covered now.
Well, and they're getting much cheaper.
They're getting much cheaper, and they're getting much cheaper. Coverage is getting better. Reimbursement's getting better. I think from a pharmacogenomic testing perspective as well, costs are declining. Coverage is getting better. We're working with an organization called STRIPE, which stands for Standardizing Laboratory Practices in Pharmacogenomics. And I help lead one of their task forces that's really looking at this question of, well, what are the issues regarding reimbursement? Where are there inconsistencies? And what are the level of evidence thresholds that are needed to say, yes, a drug needs to be covered, or yes, that a genetic test needs to be covered, or that a genetic test needs to be recommended by a professional society, NCCN, ASCO, American Heart Association, so on and so forth. So how do we standardize that message across the board, from regulatory agencies, the FDA, to professional societies, clinical practice guideline writers, to the insurers? Because right now it's quite variable, and that makes it very challenging to then translate that to clinical practice. And so if we can establish those level of evidence thresholds, and we can ensure that there's evidence-based practice across the board, that there's equal access to testing, that it's covered by major insurers, and that we know there's comprehensive tests that are available for patients, that I think is going to be a major shift in these next 5 to 10 years.
Frankly, Jay, I think you're going to get us there, and I think you're going to get us there before 10 years. It'll be like 5 or less. I just see so much. I just see so much impact in you, and obviously your work at LCI speaks for itself. Thank you so much for joining us, and I really value this conversation. So is there anything that you would like researchers listening to this podcast to check out online for LCI or the work that you're doing?
Yeah, so you can find a lot of the information, a lot of the data, the things that we're working on our own website, part of Atrium Health. And many folks may have heard that we're also sort of merged with Wake Forest University. And so we really combine efforts, and then along with Advocate Health as well in the Midwest, so we're becoming a much larger enterprise, much larger footprint. So as we're thinking about all these issues, challenges, and barriers, as well as the potential impact of digital health and what we're doing here, everybody's kind of thinking about this as well. And how do we synergize all those efforts? And so I hope some of my colleagues will be listening to this as well. And I think we're all very, very excited about how we can all work on this together. And I appreciate that.
Yeah. Well, thank you so much again for joining us. This was a fascinating conversation, and I will be watching all of your work. Thanks so much for listening to the People of Precision Health podcast. To join us next time, subscribe wherever you get your podcasts. And to learn more about how we're helping to engage the humans behind the data, visit vibranthealth.com.